Thank you very much for the introduction. It's my great pleasure to be here. So I'm supposed to speak about the biology of tissue reactions. And first of all, that's too much for 10 minutes. Second, I'm not competent to do that. So I will restrict that a little bit to radiobiology of tissue reactions, which maybe fits into 10 minutes, and I guess I'm a little bit more competent there. So if we talk about tissue reactions, we always distinguish between early reactions, early radiation effects, and late radiation effects. The threshold between the two in terms of radiation oncology is 90 days after the onset of radiotherapy, which means we see early reactions within days to weeks, and we see late reactions within months to years to many years. The biology between the two is different. Early radiation effects are seen in what we call turnover tissues, renewal tissues, where there's a fine balance between permanent cell loss in the one end and permanent cell production on the other end. And what we do by radiation exposure of these tissues is we impact on proliferation. We impact on cell production by proliferating, or some people say by stem cells. And by doing that, we cause a decrease in cell numbers, hypoplasia, because cell loss is ongoing. Cell loss is ongoing at its physiological rate over a wide range of doses. Cell production stops, so we get hypoplasia, we get a reduction in stem cells. In the end, if the dose is high enough, we get sort of threshold cell loss, and this is the threshold where we start to see clinical effects. Reduction in white blood cells, ulceration in skin, or ulceration in intestinal mucosa. And based on surviving stem cells, surviving proliferative cells within the irradiated volume, or migrating cells from the outside, if you think of bone marrow, we normally have more or less complete regeneration in these tissues. What is important is we do have other components. We do have vascular effects, we do have inflammation, we have immune effects in all these tissues. And at the moment, it remains a little bit unclear, and this is why there's a question mark. It remains unclear what the interaction between all these other effects and the true, let's say, turnover effect or renewal effect of radiation is. So this is one of the topics where which we have to focus on. What is important is the latent time to the clinical manifestation of these effects is largely independent of dose. It's depending on the renewal rate of these tissues. In contrast, the maximum severity and the duration to healing, the time to healing, is depending on the surviving proliferative cells, and thus is depending on dose. This is the very primitive radiobiology of early radiation effects. Late radiation effects are a little bit more complex. So we have always several components: parenchyma, endothelium, fibroblasts, and we have the immune system, macrophages mainly, but other immune cells which contribute to this orchestrated response. So what we get is parenchymal damage within the irradiated volume. That's important, I'm coming back to that in a minute. So we get loss of function within the irradiated volume, and normally as we are losing blood vessels, as we get scarring of the tissue, there is no regeneration. What is important is there are interactions between different organs. If you think of the thorax, there are interactions between the lung and the heart, which are regularly both exposed to radiation, and we have to have that in mind if it comes to risk of clinical manifestations of these effects. What is also important is the latent time shows an inverse dose dependence, which means if you are exposed to low doses, which is more and more the case in radiotherapy and radiation oncology, then it takes a longer and longer time before the clinical manifestation, and you have to wait for that time in order to get an estimate of the true risk of this radiation exposure. I'm coming back to that in my last slide. There's a third sort of type of radiation effects, which we call consequential add effects. What I told you so far is by irradiation we are causing damage to epithelial tissues, turnover tissues, which cause an early radiation effect. On the other hand, we are causing damage to endothelium, fibroblasts, which result in late radiation effects. And now what happens in some tissues is that the early radiation effect is associated with a sort of breakdown of a protective barrier, the epidermis of the skin, for example. And by that, you can get additional secondary damage to the target cells of the late effects endothelium and fibroblasts. And by this pathway, you can increase the risk for late effects. This is important because you can get an estimate of that risk by the clinical manifestation of the early effects already. Now, what is important is we have to concentrate on individual symptoms rather than organs. This is just an overview over the individual symptoms which we can see in radiotherapy patients after irradiation of the rectum. And that includes incontinence, bleeding, mucosal changes, and obstruction. And all these endpoints, of course, have different target structures. And all these target structures, maybe dependent or independent, have their own radiobiology, their own dose dependence, their own tolerance. And we have to have that in mind. We cannot talk any longer about tolerance of the intestine or tolerance of the rectum. We have to focus on individual symptoms and their individual radiobiology. This is just a misleading overview slide over the radiation tolerance of some of these organs. And here you can see it covers the entire range, from relatively low doses like the bone marrow or the islands, which we hear about later. The heart is not even included here, up to very high doses for the adult bone or the CNS. So we are seeing symptoms all over the range, and this is whole organs. This is not individual symptoms. I just want to remind you of that. Now, what are the radiobiological parameters? The first one is recovery. Recovery means dose rate and or fractionation effect. This is a study in mice looking for pneumonitis, decreasing dose rates. What you can see is the isoeffective doses. The dose to get a certain effect in these tissues, in these animals, is increasing if you decrease the dose rate. In this case, down to, I think it was 2 gray per minute. That takes 27 hours. That's about the maximum which you can do in animals for local irradiation of individual organs. So we are not really clear what happens in the low dose region here. And some people say it levels out. On the other hand, there are some in vitro, I have to say, indications that it needs a certain damage in order to stimulate these recovery processes. I always say in vitro, you can show almost everything, what you want, if you do the right experiment. We don't know what happens in vivo. So we have to be a little bit careful there, and there's a large question mark, at least in my mind. The fractionation effect in radiotherapy shows about the same, an increase in isoeffective doses, in equi-effective doses, if we decrease the dose per fraction, if we increase the number of fractions. That's the same phenomenon. Another phenomenon which is shown here is the increase in exposure time. So in this case, if you look at these individual panels, I'm not going into any details, they all show the same pattern. If you increase the overall exposure time beyond, let's say, 1 week, then the isoeffective doses, which is a measure of the tolerance of the tissues, the tolerance of the tissue increases if you prolong the overall exposure time further. And this is a phenomenon, repopulation, sort of wound healing response. The tissues, after 5 or 6 days, realize that there's damage, that there is this increasing progressive hypoplasia, and they respond to it. They respond by changing their proliferation patterns. That's a very complex thing. And this results in the end in increasing tolerance in these, as I said it already, turnover tissues. So that's a phenomenon in early responding tissues. Recovery was mainly, or is mainly seen in late responding tissues. I briefly talked already about the volume effect. And here we have to distinguish between 2 types of tissues. One is organized in parallel, which means we have functional subunits which function independently. So you can sterilize a couple of them and you don't see anything. Only if you reach a certain threshold, then you see a clinical effect. So a surgeon can cut out part of the liver without a clinical effect, and if it reaches a certain threshold, then you see the effect. On the other hand, we have a serial organization where one of the subunits is organized after the other. And if you kill one, you just kill all the downstream function of these tissues indirectly. So lung, liver, kidney would be examples for the one, and spinal cord, esophagus for the other. But always we do have, in these parallel organized tissues, we do have vasculature, which per definition has a serial organization. So it always is a mixture. What we need to know is, I told you about all these pathways which are involved, inflammatory responses, which we in the end see in the animals in vivo as tissue effects, and we need to clarify all these pathways in order to, I call it damage processing mechanisms or pathways, in order to identify suitable early biomarkers. Also for late effects, because I don't want to wait for 15 years to see what a radiation exposure implies in risk in the individual patient. And also we need to know about these mechanisms in order to develop what I call mitigation strategies, in order to develop strategies to ameliorate the radiation effects or to prevent the radiation effects. So, in total, I told you about the mechanisms leading to tissue effects, which is radiosensitivity, of course, recovery, the dose rate effects, repopulation, the overall treatment time, the irradiated volume, very briefly, and in the end, radiopathology. This is what we need to know in order to understand normal tissue reactions to radiation exposure. Thank you.